thanks to smartphones, social media, and Zoom calls, people globally are connected now more than ever. But research also shows a steep rise of mental health conditions that leave many feeling isolated and lonely. So where's the disconnect? The Surgeon General even came out recently saying that loneliness poses health risks as deadly as smoking up to 15 cigarettes a day. Hi, everyone. I'm Amy Exum, licensed mental health counselor and community health manager at Baptist Health, and I'm your host for today's important discussion. A fourth of people worldwide suffer from mental health diagnoses, whether it be anxiety, depression, bipolar disorder, schizophrenia, or even eating disorders. But because mental health issues are often misunderstood, underdiagnosed, and stigmatized, many people suffer in silence. Here to discuss some common myths and facts about mental health, and also about the good news that there is help, we're joined by two mental health experts, Baptist Health neuropsychiatrist, Dr. Rachel Rohaidy, and neuropsychologist, Dr. Rafael Rivas-Vasquez. Thank you both for being here today.
Thank you for inviting us.
Pleasure to be here.
Fantastic. So before we dive into today's subject, I want to remind our viewers to send in your requests or any questions and comments that you have throughout the discussion. We're here for you and happy to answer any questions you may have. So first question, I'd love to turn to Dr. Rohaidy. Mental health is a very taboo topic for many, and one that a lot of people are ashamed to talk about because they're afraid others are going to see it as a sign of weakness or the result of just bad decision making. And many of those people have probably been told that directly to them, right? So is there any truth to that? And what factors do you see play into mental health issues?
So unfortunately, you're right. We've been under the taboo kind of tab for forever. And even though things are getting better, we're starting to talk more about mental health issues. We're starting to have those conversations. It's still a very taboo subject. I do continue to have patients who are very fearful of coming in, very fearful of speaking out. I don't want anyone to know. Does this really have to go through insurance? So there's still a lot of fear out there. But the good thing, again, is that we are having those conversations. And so webinars like this, bringing things to the forefront, talking about them, normalizing them, really does have a positive impact on our conversation in the community.
Dr. Rohaidy, could you just give us a brief overview? If it's not bad decisions and it's not weakness, can you give us just an overall example of where do these mental health diagnoses come from?
Absolutely. So, besides what we do, whether it's habits or learned behavior, right? There is something to the neurochemistry, the biochemistry of the brain. The impact that trauma has, the impact that early drug use has on a developing brain, all will impact what we see as adults. Genetics, huge part of what we see, right? So I have a lot of patients that ask me, well, my dad had this, I'm going to have that. No. So we look at risk factors, right? So risk factors are things like genetics. It just means you're at a higher risk, doesn't mean you're going to have, right? Peer groups, whether or not there is trauma, whether it be physical trauma or some kind of psychological trauma to the brain. So we look at everything. And so we know, because the science is growing, and we've had amazing research being done on the brain past few years. So we do have measurable outcomes, things that we can measure and we can see that really tell us that there is a biochemical, there is a neurological basis, not just I have a bad habit, let's say.
Thanks, Dr. Rohaidy. Yeah, it sounds like, we're such such complex beings as humans. And so Dr. Rivas-Vasquez, I want to turn to you. You know, mental health issues can differ in symptoms, just like we're all different as people, in their severity, their timing, and many suffering through these mental health issues can often hide their struggles, as Dr. Rohaidy referred to earlier. Are there always visible signs, and is it always easy to diagnose?
So there are not always visible signs, and sometimes these things can be tough to diagnose. And remember that most of these disorders, if not all, exist on a continuum. You know, these are not dichotomous diagnoses that you are or you're depressed or you're not, you are anxious or you're not. And there's there are borderline cases of folks who have some symptoms, mild, moderate to severe. And by definition, I think as folks become more symptomatic and increase in severity, there's more functional impairment. So those are the ones that are easier to spot because, you know, by definition, they're not going to work. They're not fulfilling responsibilities. Across the board, the good news is that there are treatment for those folks. We want to make sure that we're capturing everyone. And we know that while the moderate to severe cases might be the more visible, apparent to those around us, apparent to those that may push someone to get help, we know that folks even with mild illness struggle, that folks with mild illness are still under distress, are still not doing their best, not fulfilling all of their obligations as well as they could if they were symptom free. So those we want to make sure we're accessing all folks, not just with moderate to severe illness that are brought in by family members, by friends who are in such a degree of distress that they're getting in trouble at work. We want to capture folks who have even mild illness and are, you know, in distress, sad, down, mildly anxious, and it's impacting their work, their social interactions in some fashion.
Thanks, Dr. Rivas-Vasquez. And thinking about what you shared, you know, these symptoms that are not so obvious. I feel like somebody walks into an emergency room with a broken arm, it's pretty obvious, whereas these symptoms may be masked because of the shame that's associated with some of these mental health diagnoses. Could you give us just a couple examples of some of the common symptoms or signs that you see with some of these disorders you mentioned earlier?
So, you know, the two most common groups of disorders are the mood disorders and the anxiety disorders. So major depression, which is, and again, I think the other thing for folks to realize is that depression and anxiety are normal human, you know, emotions, right? Reactions to stressors. So I think that makes it tough because folks don't understand when they tip over from normal variants of sadness, feeling down, normal mood fluctuations over the course of a month or several weeks to having more persistent, you know, pervasive symptoms, a number of symptoms that are then getting in the way. So one of the things that we do as professionals is that we apply our diagnostic criteria and we're able to make the distinction between what are more kind of normal adjustment reactions to stressors that are taking place, and then what are more manifestations of more significant disorders that we need to intervene and initiate formal therapy. But I think for the common ones of anxiety disorders, which everyone gets anxious, you know, anxiety is neurobiologically ingrained in a very adaptive response to things. So our job is to make the distinction: when is someone having a normal stress reaction to things that are happening at work, in their family, and we can talk them through that. When does it spill over to be more persistent, to having excessive worry about things, reaching the point of having panic attacks, right, which are going to require intervention? Depression, when do symptoms of disinterest and sadness start to be more persistent, day in, day out, and then you start impacting sleep, energy, appetite, concentration, and these symptoms start to amass in a way that we feel that we have to be more aggressive in intervening. And you're right. This is not like, we don't have objective measures in terms of, we don't have a blood pressure cuff. We can't do blood draws. It would be easier if we could. Think about how you treat hypertension, how you treat, cholesterol. You go to your physician for, your annual physical, and they almost tell you, hey, you have high blood pressure, you have high cholesterol. That's not the case here. We mental health practitioners are really reliant on individuals to tell us and be very active in telling us their level of symptomatology. We can inquire, of course, and we should be inquiring, mental health practitioners and primary care practitioners, but it's really up to the patient to tell us the degree of distress and the symptoms they're having.
Right. Yeah. And to your point, a lot of times I have people come to me and say, Amy, I think I might be depressed because I have this going on and that going on. And I say, wait a second, if there was anybody else that was going through the same thing, it just makes sense because you've had all these life changes. So it's hard sometimes because we don't have that baseline. I feel, from anecdotally, from my experience, especially with our younger generation, we see them being so much more in tune with their emotions, but that doesn't mean that there's no problems there. And studies show that young adults aged 18 to 25 have the highest rate of mental illness, while also showing the lowest rate of getting treatment. Some feel doomed at the thought because they think they can't be treated or cured or something's wrong with them. So Dr. Rohaidy, are mental health issues treatable?
So that is a really good question. And, to kind of piggyback on what Dr. Rivas-Vasquez said, right? So you can't go into an emergency room and say, well, I'm depressed, and they take a CT or an MRI and they find it and they say, all right, here it is. Let's put a cast on it. Let's give you some fluids, or let's remove it, right? It meant psychiatry, psychology, it doesn't work that way. So we can control symptoms, absolutely. And I think that is the history of psychiatry and psychology is the control of symptoms, right? But what we want to do also is we want to empower our patients to make lifestyle changes, to make better choices so that they don't have to rely just on medication, right? And so I think that is where there's a fine line in where a lot of us treat. Certainly exercise, good sleep, eating healthy is not going to cure, right, depression or panic, but it may alleviate some symptoms. So that continuum that was talked about with mild symptoms versus moderate or severe symptoms, right? So, when patients are finding that they are struggling, there are certainly things that they can do because it helps. You're kind of taking control of your life. You feel like you're the one in the driver's seat there, to help that along and hopefully to alleviate some of this frustration or stress or sadness before it gets to a point where the symptoms are so severe that they are now interfering with daily function. We don't want our patients to get into that zone of severity, right? So for psychiatry, things are, we offer treatment, but it doesn't necessarily mean that there is an absolute. There's no cure, right? So again, it's not like ortho, where you go in, you've got a broken bone, they fix it, that's it, you're cured, right? Or like some cancers, right? You're cured after chemo or radiation or whatnot. With psychiatry, it's very tricky. So we want to do the best that we can to empower our patients, take control of their lives, control what you can, right? The eating healthy, getting sun, getting out, not isolating, taking your appropriate vitamins, things like that, right? We want to give you the power to take a little bit of control with your life, but also know that there are patients that will require sometimes lifelong medications. So things are containable. We can certainly diminish or lessen some of these symptoms, right? But whether or not we can get rid of them completely forever, there's kind of a gray area in that.
When you talk about that, it makes me think a lot about type 2 diabetes, right? You manage symptoms, you can have great quality of life. You have all these things that you need to do for yourself, for your loved ones, but
Right.
It is possible. I think sometimes when people hear, mental health issues may not be curable, they get stuck, like Dr. Rivas-Vasquez was mentioning, in this black and white. But if you look at a lot of our medical diagnoses, even you're talking about the broken bone, I've badly twisted my ankle before, and my physician says, "Hey, Amy, you've got you're susceptible in that area now."
Right.
So sharing that information, as both of you have said, when you go in to see your provider and being very transparent, which can be intimidating, to be quite honest. It's not always easy to share some private things that you may have not shared with anyone else, but as you hear both these physicians saying, it's so important to be able to give them all those pieces of information so that they can help you the best and you can get that resolved sooner rather than later. But talking about that disclosure that patients give you, Dr. Rivas-Vasquez, many people suffer from issues like depression that you mentioned, or some sort of trauma Dr. Rohaidy mentioned. What would you tell those folks who are desperately seeking to heal? What steps would you share with them, and what do they need to do to help themselves?
Contact your professional. Make that appointment. I think that there's probably even moving beyond mental health. I don't think folks really like going to the doctor anyway. I mean, I think there's a group of people that like going all the time, but most people don't like going to the doctor anyway. So let alone for this. And Dr. Rohaidy is right. There are some cases that there are going to be chronic conditions that need to be managed over time. Maybe combination therapy of medication and psychotherapy are effective. And one of the things that mental health professionals are going to do is assess what's the degree of severity, what's the appropriate treatment, and where on that continuum do you exist. So be active in seeking that consultation. Your primary care physician is a great point of entry. I love that Baptist has started integrating mental health in their primary care sites, right, Dr. Rohaidy? I love that. I think it's a great model of care, but I think that there is hope, right? We can make people feel better and address the symptoms, give them some relief, and enhance functionality, and then hopefully give them the tools that they'll be able to make those changes. And we'll be dealing with a percentage of folks that after treatment are going to regain their typical level of functionality and move forward. Others are going to have a chronic condition, but that's what we do, right? We make that determination. But certainly, what do you tell folks who are wondering whether it's time to go see someone? If you have a question about it, go see someone.
Yeah, I as a mental health provider, if you come to me and I think that there's no major issue, and I know, having personally worked with both of you, that you would tell somebody, hey, you're going through a tough time. Here are some things you can do. If you want to come back, I'm here for you. But you're doing okay, right? This is X, Y, and Z. I want to turn to Dr. Rohaidy and talk about something that I know is on a lot of folks' mind. So one consequence of undiagnosed or untreated mental health diagnoses is suicide. And studies show suspected suicide attempts surged among young people during the pandemic. About 73% of them were children between the ages of 10 to 12 years old. What are some signs that a child is suffering to that point? What is the first step to get them on the road to recovery, and what can you share with those parents?
Right. That is really tricky. A very, very troubling numbers that we did see during the pandemic. And so what is typical is irritability in a child, right? So you're looking at anger outbursts, inability to tolerate any kind of stress, right? So if you're looking at anger, you're looking at not necessarily lashing out, but just that irritability all of a sudden in a child. You can see also isolation, extreme changes in behavior, right? So, and that's where that irritability comes in. My child was once this way, but now is this way. And not just at home, right? We're looking at changes in all spheres. It's school, with friends, with family members. So you're looking at everything, extreme changes in behavior. One thing that I do caution parents about a lot, and being a mom of 3 young kids, I have to be very mindful of, is the influence of our amazing computerized telephones, right? They're not really telephones anymore, at least not compared to when I was growing up, right? These are mini computers. And so you need to really limit internet use. You need to know what your child is looking at, and you need to have those conversations with them. I think that we all use some of these devices as great babysitters, and there's definitely a time and a place for them. But 24 hours a day into like 3:00 a.m. is not the place for them, right? So I think limiting internet use, limiting social media, because we do see a lot of these attempted suicides and completed suicides related to things that are happening on social media, right? Especially with like the bullying that has gone on. And so it's very concerning. So when we had the pandemic, everyone was fearful. And so then on top of that fear, you're isolating people because you can't go to school, you can't meet your peer group, you can't go to work. And so the population that I think we really didn't think about are these children, right? We always think of the parents, oh, we have to be at home and we're taking care of everyone. And so we're working, but it's the children that really had, I think, an even more significantly negative influence with all of this. So isolation and these devices really need to be put into check, and it's up to the parents to do that. But as soon as you see some of these concerning behaviors, or you even get a whiff of maybe there's something going on, is opening up those conversations, trying to have these family dinners, right? Don't dinner and then everyone runs to their room, right? No, actually meet as a family and bring back that thread, have those conversations. And if you're still concerned, go see your pediatrician, go see your doctor, go, talk about these things. There is help out there. And one of the good things that we did have come out from all of this are these fantastic platforms, right? So we have, I was kind of bad mouthing some of these devices, but on these devices, we have like Zoom, and we have, Doximity, and the Care on Demand, and we have all these fantastic platforms where we can reach out for help. And I think I definitely encourage parents, again, have those conversations, talk to your child, talk to family members, and reach out to your physician.
Yeah, for anybody out there who might be struggling themselves or have somebody who struggles, please dial 988. You can dial it from any touch tone phone. It is the crisis hotline. You don't necessarily have to be in a crisis at that moment, but there is somebody to talk to you 24/7 to help you or your loved one. And that is just the continuous message I've been hearing from both of you today, is that there is help and there is hope. There's more resources. We could do with more resources, but there's more now than there has ever been. And with these different populations, of and age groups, there's different challenges. And I think one of the things that I would experience as a provider, it was just, this sadness come over me when I hear a parent come sit in front of me and say, well, I thought it would go away. I can't, I'm sure you have both heard that many times. I thought they'd grow out of it. I thought it would go away. I thought it was a phase. And what I'm hearing today is, don't wait, just ask the question. And so we're at actually our last question for today, because we're running out of time here. But Dr. Rivas-Vasquez, I want to turn it over to you, talking about those different populations. When it comes to men, dealing with health can be a little more challenging because there's been generational stigma about men talking and showing their feelings. What is a good indicator for men to take notice to propel them to talk to someone about what they're feeling?
Irritability, apathy, and increased alcohol or drug use. So when you see increased anger, overt expressions of aggression, irritability, when you see isolation and pulling back from the typical things that you do, and then increased substance use, are probably the three big things for men. Just, neurobiologically and socioculturally, we're not big talkers, right? As a whole, as a group. So we tend to demonstrate our internal distress and dissatisfaction behaviorally or motorically rather than talking about it. So you have that, brain and socially determined impact. And then you also have the increased issue that we're not supposed to access care because we're supposed to be, big, strong men who don't reach out for help. And it is supposed to be a sign of weakness, for us. We certainly, mental health professionals do not view that, don't view it that way at all. But I think most of society and most men that I talk to feel that it really takes a lot to have them come and sit down in front of us.
Dr. Rivas-Vasquez, that's great information. Because of everything that you mentioned, and they may not be as proactive as others to reach out. If someone does have a loved one that's a man and they see some of these symptoms, would you suggest that loved one reach out to them, say anything? Do you think it's better if they figure it out on their own? What would you suggest in those situations? And I know it differs case to case, but generally speaking.
Yeah, I think that more often than not, certainly always for that family member of the gentleman who they suspect is going through something difficult, be supportive, but also encourage them to speak with someone. And maybe the primary care physician is an easier sell. Maybe offer to go with the gentleman to the next visit with the primary care physician. But if nothing else, and by the way, if someone is going through something difficult, male or female, it's not a bad idea to go see your primary care physician anyway, just to do a good good lab assessment, see how they're doing. And then, by the way, while you're there, why don't you tell them about what's going on emotionally as well? So that just makes good sense. But oftentimes for men, as well as geriatric patients, believe it or not, they're more comfortable speaking to their primary care physicians and not speaking to a mental health practitioner. So oftentimes that's the point of entry through primary care. But certainly, I wouldn't necessarily sit back if a loved one was going through something difficult without being not only supportive but also encouraging of them accessing care.
Thank you, Dr. Rivas-Vasquez, and thank you both. This has really been a great conversation, some really good information. You know, we have these fantastic providers here to support you. Please take advantage of them. And to our viewers out there, if you're ready to get a hold of your mental health, go to Care on Demand app and type in the code SELFLOVE25, that's one word, for 25% off a mental health therapy visit with Baptist Health. Also, be sure to hit the subscribe button on the bottom of our channel here to keep up with the latest health and wellness information and tips from our experts. You can connect with us on social media. As we see, Dr. Rohaidy's turned to a fan of some of it. So Facebook, Instagram, Twitter, TikTok, and LinkedIn. Don't forget, we have a resource blog for the latest news at baptisthealth.net/news. You'll find a link there to all the episodes of our Baptist Health Talk podcast as well. And on behalf of everyone at Baptist Health, stay safe, stay healthy. Thanks for watching.